All right, good morning. Let's do it again. Thank you, Greg. We appreciate it. He literally is headed to the airport right this second, so we appreciate having him here with us this morning. I'm going to introduce our next speaker as Dr. Brad because I cannot pronounce her name, so she'll have to do that for us all. But if you have, again, if you've been on LinkedIn or had anything to do with a lot of social media and sleep medicine, you certainly would have seen Dr. Brown in some educational activity related to sleep. She's been a guest speaker at many sleep conferences this year already, and probably still a few more to go. She's currently the CEO of Restfulsleepmd, and you should all go to the website and check out Restfulsleepmd. But it's great to be able to make sure that we, in addition to the sleep apnea patients that we all work with and deal with, insomnia patients, that we don't forget our kids. And Dr. Brown's going to talk to us this morning about children. But prior to her new venture with Restfulsleepmd, she was an attending physician at Children's Hospital of Philadelphia. So she's been in the trenches with those kids and helping to take care of the little ones for us. And we have what a challenge that can be. So please give a warm welcome to Dr.
So much, Robert. Thank you for that warm introduction. Hi, everyone. So, one thing I always say, of course, is that kids are not little adults, right? So their needs are different. And based on all your experiences, right? I'm sure many of us are parents or have worked with parents, or you have parents coming to the sleep lab, and let's not forget that. And I'm just so thankful that I get to share some of my experience, some of the research, and really just help create an awareness of just how important it is to make sure that our kids' sleep is prioritized, and also to be able to give parents some tools, right? When they show up and say, well, I can't sleep because my child doesn't sleep. And, there's some objectives that I'm going to have us go through at the end of this. And one is that we're able to identify what the various medical and behavioral concerns in children are, that you're able to develop an evidence-based approach for managing behavioral sleep disorders. And the reason why is most times you may have come across a talk on sleep apnea in kids, right? Or restless leg syndrome. So I really want us to go to the behavioral aspect, which turns out to be a major part of sleep in kids. Anyone can relate. That child that shows up 20 times at bedtime to say they want another hug, right? We're going to be talking all about that. And then, we'll have some fun with some case-based examples on behavioral sleep disorders. So now, how important is sleep in children? So the National Sleep Foundation has this incredible poll every year where they look at different aspects of sleep health. And so in 2014, they did this really cool survey where they looked at kids' sleep and said, how important is kids' sleep to parents' sleep? And so they looked at different aspects. They looked at the impact of sleep on child's behavior, child's performance, child's health and well-being, as well as child's mood. But they didn't just stop there, because it's not all just about the child, right? They looked at how those things impact the parent's mood, the parent's health and well-being, as well as the parent's performance at work. And what you can see here, just to orient you, so you can see like the dark blue just shows that these are the people, this percentage said, well, sleep is really, really important in, the parent's mood, health and well-being, performance, as well as the child. So not just the child alone. And then also for those that said very important, that's in orange, they also had quite a majority, and very, very few did not feel that sleep was important. So again, that goes to emphasize how important it is to pay attention to kids' sleep. Now, when we talk about sleep in children, what impacts does that have on their functioning? So if you have too little sleep, if you have poor sleep quality, if you have difficulty falling asleep and staying asleep, or daytime sleepiness, it ends up causing this sort of bi-directional relationship where you have an impact in neurocognitive functioning and academic function. You have a negative impact on their social, emotional, and behavioral function and physical health. And that also then feeds back to cause, poor sleep quality and difficulties with sleep. Now, when we look at sleep it's also important to look at it on a very broad context, right? And so this, some of my colleagues actually looked at this, and what they found was there are individual factors that can affect sleep in a child. And you also have to put that in the context of family factors as well as neighborhood and social-cultural factors. So for instance, if you have a child that has sleep apnea or poor sleep health or insomnia, right? It's going to affect that child's health and well-being, but it's driven by different things. It's driven by the temperament, right? When I had sleep is personal for me because I didn't sleep. I had struggles with insomnia and sleep deprivation as a trainee, right? And then on top of that, my child showed up and they didn't come with a manual. They didn't come with a memo that said, listen, your mom didn't sleep well, so just behave yourself. No. So my kid had reflux, was cranky, just colicky, and that affected me. So his temperament was sort of something that also impacted his sleep, right? And then there's race and ethnicity, right? We know that people who are of African American race tend to have more insomnia, more sleep conditions, right? So that is an individual factor. Their biology, their genes, and things like that play a role. And then we're looking at it in the broader context of the family, right? What is the family structure, right? Is there chaos in the family, right? What are the resources that's available? What are their beliefs about sleep, right? Is there family stress? Is there perceived discrimination? All those things affects the child's sleep as well, right? So it's not just go to bed and sleep, right? There's a whole lot of things that drive this. And then when we step back and look at the neighborhood and broader socioeconomic factors, right? Pollution, noise pollution, air pollution, right? Light pollution, all those things impact a child's sleep. Insurance coverage, right? Again, access to care, all those things are drivers to child sleep. School, early school start times, right? All those things are sort of individual, they're socio-cultural factors that end up affecting your child's sleep. Now, the beautiful thing is that we know we have a sense of how much sleep kids should get. Most children are not getting enough sleep. It's not, if I had a dollar for every child, a parent that shows up in my clinic and says, yeah, he gets 8 hours of sleep. I don't know why he's just so cranky. You're like, okay, the National Sleep Foundation has this written out under American sleep medicine. So infants are supposed to sleep anywhere from 14 to 17 hours. And there's a wide variability. Older infants, newborns are 14 to 17, infants are 12 to 15, your toddler is supposed to be sleeping anywhere from 11 to 14 hours. And then your preschoolers 10 to 13 hours, school-age children about 9 to 11, then our teenagers 8 to 10. Again, most children are not getting enough sleep. Of course, as we go into adulthood and young adulthood, it's about 7 to 9 hours. That's hard to remember, honestly. Remember. So I just usually will say 10 by 10. So a 10-year-old should be getting about 10 hours of sleep. And then, of course, when they're younger, they're supposed to get more. When they're a little bit older, they're supposed to get a little bit less. All right, so now there's quite a number of medical and behavioral sleep disorders, right? So this is just a few of them. If you look at the International Classification of Sleep Disorders, you'll see a whole gamut. But these are more of the common ones we see. So obstructive sleep apnea, restless leg syndrome, periodic limb movement disorder. Restless sleep disorder is not yet in the ICSD-3, but recently sort of discovered by some of my colleagues, Lourdes Del Rosso and all. And really it's about just those children that have very large body movements that ends up disrupting their sleep. Parasomnias, hypersomnolence, like narcolepsy, and then the behavioral issues, right? Insomnia, one of them, insufficient sleep syndrome, inadequate sleep hygiene, circadian rhythm disorders. So again, we'll kind of drive through the medical at some point during this talk, but I just wanted to focus on behavioral because I don't feel it gets enough attention. And again, these tend to be more common than even the medical sleep disorders we tend to see. So insufficient sleep in itself can be as high as 3% in children where insufficient sleep syndrome, and it varies. It's higher in teenagers. Insomnia is anywhere from 10 to 30%. Obstructive sleep apnea is 1 to 4. Restless leg syndrome, depending on the literature you're looking at, is anywhere from 2 to 4%. Narcolepsy, about 0.7% or so, 0.07. And then parasomnias vary in prevalence, right? Anywhere from 10 to 50% for nightmares to sleep terror, sleepwalking, and sleep-related illnesses. So now we're going to drill down a little bit. When it comes to behavioral sleep problems, again, those are the four. The childhood insomnia is most common, anywhere from 20 to 30% of the general population. And really, the most common things we tend to see are bedtime problems and night wakings, and then insufficient sleep, inadequate sleep hygiene, as well as delayed sleep phase syndrome. All right, so we'll talk about insomnia disorder. And, there's the two versions of the International Classification of Sleep Disorders. There's the version 2, and then there's the version 3, which is more recent, right? Now, under version 3, ICSD 3, it just says insomnia disorder. Most of us in the pediatric world are not fans of that because the type of insomnia disorder a child has will help you know exactly what you need to do to fix it, right? So the ICSD-2 really classifies it beautifully into behavioral insomnia of childhood. And under that, there are 3 problems. There's the sleep onset association, and we'll talk about that. There's the limit setting type, and then there's the combined type. And then they talk about psychophysiologic insomnia, which we see more in older children. And then there's insomnia due to an underlying mental health condition. Now, imagine just walking over to insomnia disorder. How are you going to even know where to start? So I really still tend to lean more towards using the ICSD-2 classification, but of course, for billing and stuff like that, it's all just insomnia disorder. Okay, so what's the diagnostic criteria? Just a quick review. So you should have one or more of difficulties: falling asleep, difficulties staying asleep, or waking up early morning awakenings, right? Anyone have those, kids or grandkids, those early waker-uppers? They just show up bright-eyed at 5 a.m. and you're like, no, this is not even possible, right? And the thing that's interesting, on weekends, they sleep okay, or they have a hard time. It's just so weird, but it's a big issue, especially when it causes impairment in the caregiver. So many times, these families are coming in. Honestly, I'm thinking, when you think about it, if mom slept all night or dad slept all night, they wouldn't show up in the clinic. They're showing up because it's affecting their own sleep too, most likely, right? Because if everybody was sleeping, and even if the child wasn't sleeping, if you were sleeping through it, you probably wouldn't know, right? So it's not just about impairment in the child. It also could be impairment in the caregiver. So I've seen people who say, well, it seems to be fine, doing okay during the day, but I'm not getting any sleep. And it's still classified as insomnia. And then it should happen 3 nights or more 3 nights per week or more, or for 3 months or more, and occurs despite adequate sleep opportunity, which takes us back to what the recommendations are, right? So if you're starting off with a child who should be getting 10 hours of sleep, and they're only sleeping 8 hours, and they only have 8 hours of sleep opportunity, then we need to fix that first. We need to make sure there's adequate sleep opportunity. And then it's not explained by any other, like in the context of other sleep disorders, right? So that's where we start to think, is there a medical contributor to this? And then, of course, hopefully the kids are not using substances, at least the younger ones, and not explained by any other disorder. Okay, so behavioral insomnia of childhood, sleep onset association type. I love this video, but if you look at it on YouTube, I showed this it's so good. And I was preparing for this talk, and I'm like, okay, I'm gonna show this video, and YouTube has taken it down. I don't know what's up with that, but I'll describe this. This is so funny. It was a video that's put up from, I think it's from an Asian country, because they weren't speaking English, but Essentially, this adorable baby has this incredible bedtime routine and is in the kitchen, sink, having the bath or whatever, and just falls asleep as the water from the sink, right? And then the caregiver turns off the faucet and the child just wakes up and turns it back on and then, falls back asleep. And then they turn off the faucet again and then the child wakes up. And this goes on and on and on. So this is your classic sleep onset association, right? It's that child that cannot sleep without the parent or without being rocked. Or some people say, well, I have to drive around the block for this child to fall asleep, right? Or I have to walk at night in a stroller around the house for them to fall asleep. That's sleep onset association. So they have, because we all have sleep onset associations. We all do. They're healthy ones and they're negative ones. So what's a healthy sleep association? It's that lovely for me. It's my pillow, satin pillow with my sleep mask. That's a healthy association. Nothing's wrong with that. But if I need someone rubbing my back to fall asleep, that's unhealthy, right? So if you think about it, we all wake up through the night, right? We're not just all asleep at night. Normal arousals, right? Up to 5, 6 or so. But you're able to, connect your sleep cycles and go back to sleep. But then if, for instance, this is what I tell my patients, the parent who's like, well, there's no problem when he's falling asleep, but then he wakes up so many times at night. And then I drill down and say, what's going on at bedtime? They're like, well, we rock him and then we put it down and then everything is fine, but then he wakes up multiple times. And so the thing about it is, it's not the waking up, it's what he needs to fall back asleep. So if that parent is there, that rocking is there, that bottle is there, then they wake up and they're more alert, right? Because they need that association to fall back asleep. And these kids have difficulties with self-soothing and things like that. Usually you'll see it anywhere from age 6 months to 3 years. Now, the limit setting type, right? That's the fun one. That's the 1 hour bedtime routine where everybody is just like frustrated. Bedtime is chaos, the child is crying, tantrums, a burst of energy, multiple requests. I'm scared. There's a, monster under my bed, another hug. Can I tell you about my day? Cup of water. I need the bathroom again. I'm scared. Another hug. And it's just this vicious cycle, right? And then there's the combined type, which is a combination of both limit setting and sleep association. And for the combined type, imagine that parent who's done this. I mean, you're like chasing this child around the house for an hour. Eventually, you're like, okay, I'm just going to lay with you in bed to fall asleep. And so now you have the association, right? So that's what tends to happen. Okay. Psychophysiologic insomnia. We tend to see that more in adolescents. And really, it's this heightened arousal at bedtime, that mind racing, that increased cognitive, somatic arousal, right? Their brains turn on. And we see this even with adults. And so the child, interestingly enough, is able to fall asleep when they're not trying, right? It's that as soon as I hit the bed, the switch turns on and I have a hard time switching off. And so they tend to have excessive worry about sleep and about the consequences. And so these are kids that would say things like, never going to be able to fall asleep. If I don't fall asleep, I'm going to fail my test, right? Why can't I sleep tonight? And then it just becomes this rumination at bedtime. And then we have insomnia that's due to underlying conditions. So you might have a child who has anxiety, who has depression. And so these kids may say things like, again, I can't turn my brain off. Sometimes they have fear that's based on reality. Something happened in the past, and so they're really perseverating on that. And then for most times, the way I sort of differentiate this compared to those who just have psychophysiologic insomnia is these kids have these anxious tendencies even during the day, and they just have the manifestation at bedtime as well. All right. How about insomnia due to ADHD? So now children with ADHD or other disruptive behaviors also tend to have sleep issues, and that's actually quite common. In some of the literature, anywhere from up to 70 to 80% of these kids have some type of solution. These kids could either have prolonged sleep onset, they may have, bedtime resistance and things like that. Sometimes they have a hard time settling or relaxing at bedtime. And that could be, because again, they have just that increased cognitive arousal. In some other situations, it may be because they have an underlying medical condition. So you can see how these two sort of weave into each other. So if you have a child and children with ADHD, they have been shown to have increased prevalence of restless leg syndrome and periodic limb movement disorder. So really digging deep to say what is happening at bedtime. Is the child complaining of leg pains? Do you notice the child kicking frequently at bedtime? It's really important to address that, even if you know that there's also behavioral component to it. And then in children with autism or other developmental conditions, these kids may also have a longer sleep latency. And that could be for different reasons. It could be that they have self-stimulating behaviors. It could also be that they have other disorders like restless leg syndrome. So again, these are kids who may also have sensory issues, right? And so overstimulation and just have a hard time sort of down-regulating at bedtime. All those things can impact this. Okay, inadequate sleep hygiene, one of my least favorite ways to describe sleep hygiene. I just don't like that term, sleep hygiene. I don't know. I don't sleep well, or I have poor sleep habits. Hygiene just seems like a cleanliness issue, right? Like, come on, what does using devices at bedtime have to do with, I don't know, cleanliness? That's just me personally. But it's definitely a big issue when it comes to our kids and parents too. And actually the poll, that 2014 poll by the National Sleep Foundation showed that up to 60% of parents or more have devices in their bedroom. And up to over 30% leave the TV on at night. And so a lot of times, things like that, devices, inconsistent sleep schedules, meaning that there's a shift, from the weekday to the weekends. There's a big shift in their sleep time and wake up time. All those things can affect sleep. And then also daytime naps as well, right? If you have a child over 5, they really should not be taking a nap anymore. And so if you're taking a nap, you're dropping your sleep drive, and it's going to affect your sleep at night. And caffeine consumption is also a big one. And I was really surprised to see that up to 21% of 2 to 5 year olds are consuming caffeinated beverages. So it sounds weird, but you should ask, because I've seen 2-year-olds with a feeding bottle with iced tea in it. Okay, no judgment. It's just something that happens. But if you don't ask, you wouldn't know. All right, insufficient sleep. I think I've talked about this before. Up to 60% of middle school students are not getting sleep, up to 73% of high school students. Of course, what does that lead to? They're sleepy during the day, they have poor academic performance. If you have a teenager that's driving, they're at higher risk of car crashes. A lot of this could also be related to the fact that there's early school start times, and there's several organizations that are pushing for delayed school start times, including the American Academy of Pediatrics, American Medical Association, the ASM, CDC, so many others. And California was the first to implement later school start time, which is phenomenal. So many states now are catching on, and there's still a whole lot of work to do. Now, with delayed sleep-wake phase disorder, this we tend to see more in our teenagers, up to 16% of adolescents and young adults. It's more common in males than in females. You may then see what you call a sort of a persistent delay in their sleep timing, and it interferes with environmental demands. Because you have this teen, he's not able to go to bed until 1 a.m., right? And then has to wake up at 6 a.m. to catch the bus for school. Like, they're gonna be exhausted. I remember I was talking to a superintendent of the school district, and he's like, that first period, the first 2 periods, like their heads are just on the table. Like, I think it's just a wash, and it's just wrong, because our teenagers have sort of a physiologic delay in their circadian rhythm. And so I always will say, us asking our teens to wake up at 5 a.m. or 6 a.m. is like us being told to wake up at 3 a.m. and do some geometry problem or something. Like it's wrong. It's just not, we can't expect that because they are in their circadian rhythm at that time. They should be sleeping. But we're putting them on the bus, it's night out. We're wondering why they're struggling with school. And the other thing is, they might also develop insomnia-like features. Why? Because you are the parent of this teen who says, well, I'm not sleepy, right? They were going to bed at 8 p.m. or 10 p.m. before, and now 12 a.m. You're sort of hearing them walking around the house. And so it becomes this battle. And so now they finally decide they're going to listen to you, and they go to bed, but they can't sleep. Again, it's against their physiology. And so sometimes they may end up developing insomnia where their mind is racing and things like that. And the thing about it, the way I differentiate that is to say what happens either on the weekends or what happens on vacation. Or if you were supposed to choose your sleep schedule, what would that look like? And that really sheds a lot of light. Many of them will say, well, when I go to bed at 2 a.m. on the weekends or 1 a.m., I fall asleep within 10 minutes. When I go on vacation and I'm allowed to sleep in, they sleep okay. Once they fall asleep, they're able to stay asleep. And they would say, well, I like to wake up. I would love to be able to wake up at 10 a.m. or something, right? So that gives you a clue. But if you have a child that says, well, even on the weekends when I go to bed at 1 a.m. or 2 a.m., it still takes hours to fall asleep, then that's more likely insomnia. So you can see that there's a difference. Okay. All right. You guys still with me? Awesome. So we're going to go into intervention. This is the fun part. This is what I get to do all day, every day. All right. Sleep hygiene. There it is again. Super important. Really, really important. Very foundational. It's the basics. Kick the devices out of the room. Set consistency. All that good stuff. Most times, if there's a sleep problem, it's not enough. But that being said, especially in pediatrics, studies have shown that there's strong evidence in appropriate sleep hygiene, decreasing sleep onset latency, decreasing night wake-ins, improving sleep duration, right? It's more robust for infants and young children, but then definitely we see it still in school-age kids. So what are those? Sleep in the bed, that is for sleep. Have a consistent schedule on the weekends so that we're not getting these fluctuations in their internal clocks. Having a bedtime routine that is short, sweet, moving towards the bed. I usually would say 20 minutes, tops 45 if there's a bath or a shower involved. And then you want to have sleep promoting conditions, right? The room should be cool, should be dark, should be quiet, or have a white noise machine. You have a child that doesn't like quiet completely. Of course, avoid electronics and avoid caffeine. All right. So specifically when it comes to sleep onset association, remember that's when the child needs a parent to be there and will wake up frequently and need that parent to be back there. And this is fun. This is the thing about it. When parents come to me, they say, my child wakes up many times. They usually won't say, my child needs me to fall asleep. My child wakes up many times. Some of them will say, my child needs me to fall asleep. But then I always say, okay, let's go back to bedtime. They're like, I'm telling you, I promise you, doc, they fall asleep okay. Okay, but I want to know what's going on at bedtime. And then you hear about what goes on at bedtime. And what goes on at bedtime is the child is there, twirling mommy's hair on top of mommy, and it's like crazy. Eventually falls asleep, and then mom has to be like a ninja, kind of make the way out of the bedroom. And then within 2 hours, the child is awake and crying, right? And so it's this horrible vicious cycle. So I say, you know what? I don't want you to even bother with the nighttime wake-ins right now. I need you to work at bedtime. We need that child to be able to fall asleep independently. We need that child to be able to develop their own sleep confidence, because that's what it is. That child does not feel confident in their ability to fall asleep independently. And so we need to restore that confidence in that child. Because when you do that, and the child wakes up in the middle of the night, like we all do, the child feels safe. It's like, okay, the last time I fell asleep on my own. I'm just gonna continue sleeping on my own, right? So that's really what we do. Now, in that process too, in some situations, especially if you have a bedtime routine that's super long drawn, and it's taking a long time to fall asleep, sometimes we'll implement what we call bedtime fading, which is you may give them a temporarily later bedtime, and then as soon as they're able to fall asleep sooner, you move it earlier. So it's really temporary. So there are three broad ways of doing this. There's the unmodified extinction, which many of you may have heard of, the infamous cry it out. Nobody likes that because it's hard. It's hard to hear a child crying and crying for hours. Because literally what that is you just say good night, you put that child in bed, and you walk out the door and you see them in the morning. And so most people cannot do that. Some people do. The literature has shown that it's actually very effective. Within probably 3 to 5 days, you fix it. But then a lot of parents can't handle it. It's hard. The other one is what we call the camp out method. And so really what that is, it has various iterations. Some people call it camp out method. Some people call it the chair method, shuffle method. You know, y'all know out there's like all kinds of books about this stuff. But essentially what that is sort of a more gradual extension in that sense. And so you're slowly moving the parental presence from the bedroom. And then there's the last one, which is what we call the check-in method. So with that, you are, or the Ferber method, or those of you that may be familiar about Ferber, it's you're going in, and then you're leaving, and you're actually checking on them good night, just checking on the child, and you walk out the door. This tends to be a bit rough for many kids because it's like they're winding down, they're in bed, they're crying, and then you show up again, and it's like a tease. You're like, good night, I'm here to see you, but I'm not here to see you, and then you walk out the door. So many kids struggle with that as well. So I tend to see a lot more families handle the camping out method best. But I think the key, regardless, is making sure that we work with the families to find what works best for them. So with with the sort of the camping out method, again, regardless of where the families are, you really want to start with where they are. So you might have a family who's like, well, child is on me, twirling my hair, rubbing my back, all kinds of things, drinking about all that stuff. So you start with one thing. So it may be that you say, okay, you're going to sit in a chair next to the bed and just sit there quietly. And then over time, after a few days, you slowly start to move your chair out towards the door. So maybe in the middle of the room after a few days, and then to the door after a few days until you're in the hallway and gone. And the key with this is really consistency and being very clear and monotonous in your response when that child is trying to talk and get your attention. And so really we'll say things like, I love you, the money's up, it's time for bed, good night. I love you, the money's up, it's time for bed. Nothing engaging at all until the child's like, okay, you know what, I'm just gonna fall asleep. Because kids will feed off of any type of attention, negative, positive, anything. They need some kind of attention. So when you say, you know what, we filled your cup with love all day, we've had a beautiful bedtime routine, this is the time you can sleep, right? And have those conversations with them very early. You know what, sleep is good for you, sleep helps your brain, sleep helps you to be happy, sleep, they can actually get it because they know when they don't sleep well, they are exhausted. Now, for those kids who may have like a lot of pushback at that time, those kids who have a lot of limit setting issues, a bedtime chart tends to work, and you can print that from online. You can have the child color it, and then as they go through the steps in their bedtime routine, whether it's read a book or have a bath, read a book, say some prayers, hugs, they're literally checking it off and really praising them for every step of that routine. So that's really helpful. Another one I like is the timer, where you set it at limit. So for every step of the routine, okay, we're going to brush our teeth for whatever time. And then the timer goes off, oops, time to move to the next stage, time to move to the next stage. So that's also something that's really helpful. And you blame the timer. So you as a parent don't look like the bad guy. And then I love the bedtime pass. That's also an option too. Again, we sort of adapt this for different, child age, child temperament, parent values. And this is where really having conversations with what's important when the family comes in. So with the bedtime pass, literally you color two passes or just cut up two pieces of paper, whatever. No matter whatever how fancy you are, you do the Pinterest type or just grab two sheets of paper. And the child keeps those passes. And so what happens is for every request, right? If you have a child that has a laundry list between going to the bathroom again, checking the closet for monsters, I need another hug, sip of water, hug again, tell you about my day, all that stuff, right? They get one or two passes. And so once they have a request, it's like, okay, you give me the pass, then you give me the request, then I answer the request, right? And so once the passes are done, requests are done, we start again tomorrow. And the beautiful thing is you can also let them know that, well, if you hold on to your requests or if you hold on to your pass, you can trade it in. So for the next morning, trade it in with something, I don't know, a gift, a token, some extra iPad time, whatever that looks like, nothing too fancy. Don't take them to Target, just something very basic that's sustainable. Otherwise, you set really high standards and you may need to mix it up. And then there's the second good night, which the parent just comes back to say good night again. And really, again, lauding the child with praise, especially when they stay in bed. Okay, so for our early waker-uppers, right? Those kids that show up, isn't it creepy sometimes? I used to have, my kids are like teen and preteen now, but I would just open my eyes and they would be there, just standing over, oh gosh. So for those kids, the okay to wake clock is perfect. Now, it's just the clock that changes color because most times they don't know the time. So you need to stay in your room till 6 a.m. What is 6 a.m.? What is 6 a.m.? What is 6 a.m. in the summer when the sun is out, right? So when you have this okay to wake clock, literally you're changing the color. And so that's all they know. You don't come out until it's green. Right now it's red. And so they know that. And then you also want to set them up for success. So if you have a child who is up at 5 a.m., it's going to be hard for them to stay in bed till 6 a.m., right? So for the first few nights, you might say 5:15, 5:30, and then you now move it a little later to get to your goal. And so they stay. And then another one is the sleep fairy. So the sleep fairy is like friends with the tooth fairy. And what the sleep fairy does is the sleep fairy goes around kids' houses, kids' bedrooms, and sees which kid is still in bed till morning and leaves a token. And so you don't know when they're going to be there. So really, really important that you stay in bed so that you get your token. Again, small, cheap, tangible rewards, please, nothing too fancy. All right. For bedtime fairies, these are the kids who monsters, kids have very vivid imaginations, right? So they are thinking all kinds of thoughts. And to them, it is real. So no matter how much you say, no, there's no monster, there's no monster, they're like, I don't know what you're talking about. There's a green goober that's gonna eat me up. Fix it, right? So one thing that works is the monster spray. And usually by the time they're like 5, 6, 7, I mean, of course, they will outgrow it. But for now, this works. And you just make a monster spray. Some water, some essential oil, coloring, you label it, and you use it as part of your routine. Okay, it's time for bed. We're doing a spray, monster spray under the bed, monster spray in the closet. Anywhere else you see monster? Okay, and I love you, that's it. All right. And then you could also do the flashlight treasure hunt. Especially when you have a child who has a lot of fear of darkness. I mean, they could use a night light, but if they have really pervasive fears, it's really almost like desensitization, right? You slowly help them to build confidence with being in the dark. And so that may look like, reading or doing their bedtime routine with a flashlight on, or hiding toys and then doing like a scavenger hunt. So I need you to go find that toy in the dark. So they'll run into the room. You make it somewhere they can easily access initially, and then you start to hide it deeper and deeper. And I usually like to encourage parents with brave self-statements. I'm bold, I'm strong, I'm courageous, things like that, just to reaffirm themselves. For bedtime anxiety, we see this in a lot of our older kids, right? So there have been studies that have shown, especially for insomnia in adolescents, that you can adapt cognitive behavioral therapy for insomnia for them. But one of the key ones is relaxation strategies. So these kids are wound up tight. They're, hyper-focused. They're ruminating. So really helping them build in relaxation strategies through mindfulness, progressive muscle relaxation, breathing, visual imagery, all those things have been shown to be effective. And then another thing that works is the worry time or the worry box, especially if you have that child who is constantly worrying and ruminating and just really for what ifs, for what ifs, for what ifs. And so you want to set aside a predetermined time earlier in the day, not in the evening, where they can worry. Like, listen, you're going to just worry and worry as much as you want between 2 and 3 p.m. or 2 and 2:30, whatever it is. And for those who can write, they can actually write what they're worried about. They can write what their thoughts and fears. It might be the same thing every day. And you may need to do it like consistently for like a few weeks first. And then what happens is in the evening, when they come and they start telling you all those fears, you say, no, remember, we have worry time already. It's all in the worry box. We'll continue tomorrow. So they have that setting. And even as adults, I encourage us to have this practice as well. You know how those thoughts just come when it's dark and quiet, and you're just there with your thoughts. It kind of just bombards you. So making sure you have breaks during the day where you could just, process those things is really helping. So what about medications? Unfortunately, I think fortunately, as far as I'm concerned, especially for otherwise typically healthy children, there are no FDA-approved medications for pediatric insomnia. Because, again, you can see most of them are behavioral issues. We do have some situations, right? We have children with neurodevelopmental conditions where we would use like off-label clonidine, SSRI, melatonin, and things like that. And, with melatonin, as we all know, it's a hormone released by the brain in the evening. It cues the dark light cycle to help cue your brain for sleep. It's not a sleep aid in that sense. It's endogenously produced by our brains, but they're exogenous formulations as well. It's disrupted by light. And so one of the things I say is if you're going to use melatonin while your child is bathing in blue light, it's like the effect is canceling each other, right? And then there's also, we know that it's not well regulated, especially in the US. In some other countries, you can't get it from over the counter. But in the US, it's marketed as a supplement, right? A natural supplement. And so you can get it anywhere. You can get all kinds of preparations. In fact, there were studies, right, that I've done, PD one that was published in April, where they looked at 31 grams of melatonin gummies. So that's the one that our kids are most likely going to take. And there was such a high variation. Some of them contain CBD, which, FYI, children should not be taking. There's a few rare genetic disorders, rare seizure disorders where CBD can be used, but not typically. So some of these contain CBD. And there was such a wide variation, up to close to 300% or more in what was labeled as the melatonin content versus what was actually in there. And then what they also found, this was a little bit older study, even within one sort of preparation, there was a wide variation in the content of melatonin that was in there. So I think the take-home points with melatonin is you want to give it in consultation with a professional. One, because there are indications for melatonin in children. If you have circadian rhythm disorders, similar to adults, you may use it as a chronobiotic we tend to do really, really low doses. Actually, anywhere from 0.3 to about 3 milligrams is where I go with kids. Or in children with neurodevelopmental conditions, where you may use it as a hypnotic, where I typically wouldn't go more than 6 milligrams before bedtime. So it's important you use it right, because it can serve either as a chronobiotic or it can serve as a hypnotic. And if you use it, if you poorly time it, it can actually make sleep worse. And then another analogy I tell families is, listen, it's a hormone. It's a hormone produced by our brains. And the same way you wouldn't just pump growth hormone or estrogen or progesterone to your child, right? I hope not. You shouldn't just give melatonin just because. I think it's really unfair. It's the way it's being marketed, right? That being said, I mean, the studies that have been done on melatonin have not shown super severe side effects, but again, most of these studies are not over long term, so we don't know what the long-term effects are. There's some studies that have shown that it might potentially contribute to puberty suppression in our kids. And they've done those studies mainly in mouse models. They've not consistently replicated it in adult studies. But that being said, I think we should take it with caution. I prescribe it, but the timing and the duration is something I'm keeping in mind constantly. And then it should not replace hygiene. It should not replace treatment or addressing or looking out for medical sleep disorder. So I think behavioral treatments work. They're effective. There have been so many studies, including this multiple meta-analysis that looked at the impact of behavioral treatments on the child's mood, daytime behavior, temperament, and health. And all things were headed in the right direction. And again, we talked about the fact that this affects families. I've had families lose their jobs. I've had parents quit and just stay home because of the child's sleep issue. So it impacts. I've had families, I've seen families separate. I've seen parents walk away from the marriage because of the child's sleep. So it's a big deal. And so what these studies showed is that behavioral treatments of sleep issues improves sleep in the parents, decreases fatigue, improves well-being, decreases stress, improves marital satisfaction, and as well as mood and mental health. So there have also been some long-term studies, because a lot of things I've heard also is, am I emotionally damaging my child? My child's going to be scarred. My child is crying or should not cry. And these studies actually looked at the long-term benefits and harm of behavioral interventions at infants, and they looked at the child all the way to age 6. And looking at both parents, child parents, as well as maternal outcomes, what they found was that there were no long-lasting negative effects, right? When they looked at sleep, mental health, parents' mental health, global health, parent global health, child quality of life, as well as the parent-child relationships. So these strategies are safe. These strategies are definitely sustainable, and they're tools that the child will use like all their lives. I'm sure many of you have patients that have said, oh yeah, I've been a bad sleeper since I was a child, right? And you're like, what happened? Like, So I think really paying attention to this stuff is important. Okay, I said we're going to drive by medical sleep disorders, because of course we have sleep techs and respiratory techs. I'm a medical sleep physician or medical provider, expert, whatever. Obstructive sleep apnea is 1 to 4% in children. Typically you have gasping. You may or may not have snoring actually in children, especially for kids who have developmental conditions that's associated with hypotonia. They may not actually have the snoring that you see. You may have pauses in breathing. Typically we diagnose with PSG. A lot of these kids also have behavioral correlates. There's a higher risk if they have adenotonsillar hypertrophy, obesity, hypotonia, or craniofacial differences. The broad strokes of treatment, surgical, it tends to be the mainstay, adenotonsillectomy. Sometimes we'll do craniofacial surgery. tracheostomy in some really severe cases. We're doing that much less now. You might do tongue-based reduction for kids who have macroglossia. And then the hypoglossal nerve stimulator is actually coming up, especially in children with trisomy 21 who are intolerant to CPAP. The medical treatments include continuous positive airway pressure, bilevel positive pressure. If they're obese, we'll recommend weight loss, but of course, usually you need a bridge for that until they achieve good, appropriate weight loss. Intranasal steroids and Montelukast, especially if they have mild phenotypes. And then, rapid maxillary expansion, myofunctional therapy is starting to come up a little bit more now. We're seeing that in the literature. For restless leg syndrome, we have frequently movement. We use the same URGE acronym. So urge to move the legs, usually associated with unpleasant leg sensations. Rest induces those symptoms. Getting active, moving around brings about relief. Tends to be worse in the evening, and delayed sleep onset may actually impact sleep maintenance. Tends to co-occur with periodically movement disorder. About 2% of children have a genetic component. Tends to be associated with the lower ferritin level in children. Your picky eaters and all that. So many times we're getting a ferritin level. And in terms of treatment, we work on sleep hygiene, we work on behavioral stuff, iron supplementation. And a few times we'll do dopamine agonist or like gabapentin and things like that. So how about parasomnias? So these are undesirable behaviors we see during sleep. There tends to be a genetic component as well. You may see sleepwalking, confusional arousals, sleep terrors, head banging, or nocturnal enuresis. Usually tends to occur the first third or half of the night. The parent is it's like clockwork, 11 p.m., he starts screaming or starts just kind of walking around the house. And so they have these very, very automatic behaviors, and they're very hard to wake up during the event. And usually we just don't try to wake them up, because at times that actually exacerbates it and makes the episode longer. And they tend not to remember this compared to nightmares where they actually remember the contents of their dreams. Tends to resolve with age. Many times it's about safety precautions, again, and behavioral strategies. We'll do like sleep extension, because sometimes illnesses, stress, sleep deprivation tends to trigger these episodes. All right, narcolepsy is a chronic neurologic disorder that's made up of excessive daytime sleepiness, cataplexy, it's type 1, hypnagogic hallucinations, sleep paralysis, and sleep fragmentation. Diagnosis is around adolescence and usually based on your polysomnogram and your multiple sleep latency test. And in terms of treatments, it's the psychoactive stimulants, the wakefulness promoting agents, the oxybates, and behavioral strategies that actually, as important as I prescribe stimulants, I prescribe daytime naps. And so that's something that we work with the school to say, I need a spot for this child to be able to take a nap after lunch, even as part of their treatment regimen. All right. My favorite part, case examples, because I think this will help drive things home a little bit. All right, so we'll start with Isabella. This, I need you guys to, please yell your thoughts, your answers or questions out, okay? So this Isabella is an adorable 4-year-old that presents with difficulties falling asleep. She has a bedtime routine that starts at about 9 p.m. She's in and out of bed for about an hour, cries, tantrums without the parent present. And eventually parents are resorting to Benadryl to help with sleep, or they'll lay with her. They've just done everything, right? She refuses to nap, so she fights naps. But then on the car ride home, those sneaky naps, right? 4:30 p.m. as they're driving home from daycare, she falls asleep. And it's affecting her daytime function because her teacher is concerned about attention or and behavior problems. So my first question, what else would you like to know? I don't have books to give in. the right answer, but anything else you would like to know? Very, very important question, right? What time does she get to know? What else? Anyone? Yeah, anxiety or other mental disorders, absolutely, absolutely. What's in the bedtime routine? Sometimes could it be that it's stuff that's sort of revving her up instead of calming her down? Is it excessively long? Because when kids are overtired, like when we are tired, we're sleepy. When our kids are overtired, they're wired. Exactly. So that could be playing a role. Really, really good question. The environment, right? Is there a device at bedtime? Do the parents say, you know what, just hang on to this iPad because I can't deal with it anymore? Is the bedroom cool? Is it dark enough? Yeah, light, right? Really, really good. Really good questions. So, I'm sorry? It's a late bedtime, exactly. So what's your dad's? What are some thoughts? Ah! Always, right? Oh my God. Yeah. What else? So it could be inadequate sleep hygiene in the late bedtime. Maybe there's devices at bedtime. Maybe there's a very irregular and erratic sleep schedule. Maybe the bedtime routine is not coming. So it could be that. It could be behavioral insomnia of childhood related to limit setting and or sleep onset association where she actually needs that parent. It could be a drive issue, a sleep drive issue, because she's not been very late, 4:30. So maybe she's just not sleeping, right? So in this situation, how would you approach treatment? Yeah, yeah, exactly. Start working at bedtime. I might try to eliminate that now, if it's possible. Um, you know, I think that's something that at least if you eliminate the bedtime nap and you move that bedtime a little bit earlier, you don't get into that sort of reading zone. Because 9 p.m. for a 4-year-old is late. So that might be a good place to start. Yeah, exactly. Yeah. So maybe trying to get her, even if, and this is the thing we usually about between 3 and 5 year old, 3 and 5 years old, kids start to drop their daytime nap. And so the daycare may not necessarily enforce it or something. But in this situation, sometimes I'll say, you know what, let them ensure they have some quiet time. So if you create the environment where they can at least relax, say right after lunch, hopefully that helps them, sort of recuperate their energy enough to not need to fall asleep at 4:30 p.m. And then we can move that bedtime forward. I think that bedtime is absolutely needed. And then clean up the bedtime routine, make it short, sweet, set some limits. And if this is a child where mom is going in and out of the bedroom, sit with her and then gradually come out of the room. So I think that will fix it. You guys just fixed Isabella's sleep. You're experts. I love it. Exactly. It's a very good point. I think sometimes when parents are exasperated, they just like throw everything. And for some kids actually have a paradoxical response to Benadryl, where the child now becomes wired. And so really backing off on that. Thanks for mentioning that. Very kind of somewhat similar strategies, absolutely no nap, an earlier bedtime, and then setting those limits. This would be 8 years is a good one also for a bedtime pass. So you have requests at bedtime, okay, 2 passes. If he needs you to be in bed with him or in the room, then we camp out. And honestly, kids need any type of attention. Just remember that. So just being as it's bedtime, I love you. Okay, daddy needs to come for this session. All right, let's go to Jeremiah. So Jeremiah is a 10-year-old. He has excessive daytime sleepiness and chronic headaches. He falls asleep in class every day. That is not normal. There are no concerns on the weekend, interestingly. And he was previously seen actually in sleep clinic about 2 years ago. He had a sleep study issue, no sleep apnea, but he's gained weight recently. So what else do you want to know? Is he snoring? Yes, exactly. Good question. The weight gain, right? Could this be emergence of sleep apnea? Yep, we're back there again. Back to that. Yep, yep. Is he getting enough sleep? Maybe this is just insufficient sleep. See, it says no concerns on the weekend, so maybe he catches up on the weekends, right? Needs an updated PhD, absolutely. Is he oversleeping? Yeah, could he be excessively sleepy because he's sleeping too much? Could there be an underlying organic sleep problem? Could could this be narcolepsy? Doesn't need an SLT. Very good. Stress, and then there's no school on the weekends, and so that takes the edge off. Is there any underlying anxiety or mood disorder? And what's with the headaches? Is there something else going on organically? Does he need to see a neurologist with the headaches? Because that's unusual. Unless maybe, of course, if he has sleep apnea. That's also really good. What would you be thinking of because of that? Hmm. Yeah, yeah, yeah. If he has a very late bedtime, he may just not be ready to wake up in the morning, right? It may still be related to insufficiency. Oh, yeah, yeah, at this age. So we want to check that on headaches, exactly. So maybe he's straining and things like that. So, great. So what would you like to do? Or what's your diagnosis? What are some of the thoughts you're thinking? I mean, you guys think the questions that can kind of get a sense of where your thoughts are. What are some of the things your diagnosis? Sleep apnea, insufficient sleep syndrome, inadequate sleep hygiene, organic sleep disorder, or medical disorder like migraines. That could also be mood disorder, anxiety, depression, right? So I think what I want you to understand, it's not just one thing. It could be a couple of things. And so even if you got a normal sleep study, telling the parents, and this is why a lot of them come to me even for second opinion, they're like, well, he had a sleep study and they said he was normal, so they said his sleep is okay. But this kid's struggling, right? So it's really about digging deep, really good. So how would you approach treatment? I mean, that would really be dependent on what's going on. Sleep study, ferritin level, yeah, period. Is he moving his legs? What's his leg movements at night look like? That would be good if he has very restless. Are there any vision issues? Do we want to refer him to neurology or see the eye doctor? Oh, yeah, allergies too. Yeah, yeah, or video games. So really making sure we clean up that sleep hygiene. Anxiety doesn't need to be seen by a therapist. So again, you can imagine they show up and say, he falls asleep in class, he had a sleep study that was normal, his game would go. So you can see you could leave the family with so much empowerment about what else could be going on with this kid. So they don't think it's just in their heads or they're making stuff up. It sounds like video games. Diagnosis video games. All right. Okay, we'll do Tina last. You all have been amazing. You guys, I mean, all right. So Tina is 17. Anybody with a teenager in the house? Fun time of our lives, right? So Tina is here. She has difficulties falling asleep, and she also has daytime sleepiness. And she gets into bed about 11 p.m. and she falls asleep about 2 a.m. She's late here, exact, right? Or summer vacation, that's also another time. Parents are like, listen, she's just a different child during the summer because she chooses her bedtime on right? So that also comes in. But they say, you know what? Her mind is racing. She's constantly anxious. She's a type A, kind of personality, blah, blah, blah. Then you think insomnia. But I can absolutely tell you, most of the kids I see are all three inadequate sleep hygiene because what's happening? Their body physiologically cannot fall asleep until later. So they get insomnia because they're frustrated and they have to test the next day and they're like, I can't sleep, I'm going to fail my test, the world is going to end. And then they're like, you know what, I'm just going to go on TikTok right now because I need to just calm my mind down. So it's all three. So we then have to sort of parse it out to give them a plan. Right? So it will, but they don't think so because in the moment it's distracting them from their thoughts. Folks want to get away from their thoughts and they'll do anything to do that, right? So relaxation strategy would be a healthier option, right? So how would you approach treatment for them? We already talked about get all that technology out of the. You said what? Some white sound noises, practice some visual imagery, progressive muscle relaxation, some journaling, having a bedtime routine. In her case, if she has the late phase, this would be a kid I probably might put on the with some dim light in the evening, some bright light in the morning, to sort of shift her clock and then keep it there. Make sure she's not diverging on the weekends. So kind of like the color therapy. Can she go to bed earlier? You have to be careful. You have to put on, you're going to remove it gradually, especially if she has insomnia as a component. So in these cases, sometimes we'll do sort of a modified cognitive behavioral therapy with a little mini sleep restriction. Because I don't want her laying in bed. She's already in bed at 11 p.m. I'm assuming she doesn't have devices now. I'm assuming she's only purely delayed sleep days. So I don't want her to go to bed too early initially, so I'm going to move her very gradually. So we would do like a very low dose melatonin, probably about 4 hours before her bedtime, right? Make sure she's not exposing herself to blue light. Make sure she's doing stuff that's relaxing. And then in the morning, we'll expose her to bright light therapy. So either through a light box or, keep all the windows open and things like that.
Even if you want to bed at 11 o'clock, you get up at 5, 6 in the morning to school, that's still not enough sleep time.
No, so this is someone that we will work on over a period of time. It's not a fixed thing. So we'll start with that and then slowly start to shift her. I mean, I think our kids, our teenagers are struggling. And this is something wherever you are, whoever you know, to please advocate for these kids. Because if you think about it, if this is her physiology, she shouldn't have to wake up at 5 or 6 a.m. because physiologically it's hard for us. So we're going to artificially shift her circadian rhythm, melatonin, and light therapy. But it's not the permanent fix. And as soon as she sleeps and falls or trips up and goes back, we're back to square one. So it's not definitely a fix. But I need her not to fail her classes anymore. I need her to graduate.
So there's no way to ask my question because I like not really bad here. And so what if having a kid in the best situation, but they're getting really good grades? And so you don't want to, well, I know I just need to like roll a backbone and be a better parent and be like, no, back. But I think that if teenagers especially, it's like they need some of their own autonomy, right? And they need to be able to kind of like friends. So are you just going in with a lot of education around like why it's not good for her and stuff? When it's seeming like, I don't know, I just feel like it seems like a big punishment.
Yeah.
Yeah.
Absolutely. And that's a good question. Remember, mom, she's coming here because she said if she was passing classes and she was doing her dance, she wouldn't be there. So then it's pretty much almost like not a non-issue, right? If she wasn't having symptoms of daytime sleepiness, if she wasn't at a risk of car crashes, if she wasn't having anxiety that's related to her sleep, it's a non-issue. It's a non-issue because you need her buy-in. You need her buy-in. And honestly, when these kids come to see me, like literally, mom is like, "Yeah, doctor, tell her." And I'm like, "Hey, mom, I just want you to just sit right here. I'm just gonna," because you need to empower her. You need to empower her. You need to help her find her why. So for some kids, if it's a boy, maybe that he's in sports and he doesn't care about his grades. So that's not a motivation. But if he plays basketball, guess what? I'm going to talk about the 3-point throws. I'm going to talk about how he improves your performance, you know? So you meet them where they are at this age. You can't just force them because even if you hide the devices, they know how to get into other things. So you need their buy-in. They need to understand why sleep is important to them for you to be able to move forward, if that makes sense. All right. Okay, you guys fixed Tina, so well done. So in summary, sleep disorders are prevalent and persistent in children. Behavioral and medical sleep problems coexist. I want you guys to leave that truth today. Individual and contextual factors should be taken into consideration when you're addressing sleep disorders, and interventions need to be developmentally appropriate, right? What I'm going to give to Tina is different from what we're going to do with Isabella, right? And they should be tailored to the patient's needs. Here are some resources. Of course, this book, Pediatric Sleep Problems, A Clinician's Guide to Behavioral Interventions, is incredible. It's a really good book. If you want to take a picture of that. It's written by one of my mentors, but it just really has very good content for clinicians. And if you scan that QR code, you know that LinkedIn that Robert told you about, you find me there. Come say hi. Thanks for having me.
Any questions?
Oh, yeah.
Oh, 7 to 8. I was gonna say usually for kids under 3, I just stay away. For 7 to 8, I think it all comes back to what's your why behavior. 7 to 8, most kids are behavioral, so we try to address that. If it's a kid that has ADHD or autism or other things, then I might give them some of that. I start at the very lowest skills. I would start really at 5 and just enough to help with sleep concept, because that's really what melatonin helps with. And I literally almost short of making the family science, also participate in behavioral interventions because I'm like, this is not a long-term fix. This is not something that can be done just on its own.
I've had parents say, say it every night through the school year, for the last 3 years, not on weekends, not in the summer.
I would encourage, and that's the thing, the market is strong. I mean, it was like, I think, $1 billion industry at this point through melatonin. So we are fighting uphill. So I think it's really having those conversations with family, like what's the long-term plan, right? And so I just so used to it. And some kids, and the studies that have been done that are compared it to placebo, where you just give them a gummy, they just know they're taking a gummy. And they sleep. So it may not be the melatonin, but that's a good question.
Thank you. Thank you very much.